Hello, fellow zebra hunters. This is Diagnostic Atypia. Please remember, the content of this podcast is meant strictly and exclusively for the purpose of education and entertainment. The information discussed is not a substitute for your own clinical judgment. All opinions expressed on this podcast are exclusively those of the hosts and do not reflect the views of our employers or other affiliated entities. All cases discussed are HIPAA compliant, with key identifying details changed.
All right. Well, welcome everybody. We're gonna get right into it today. It's a big case. It's a legendary episode for reasons I won't spoil. Just a question for the listeners is, do you believe in aliens? Are we alone today? All right, Mike, we're gonna go into it. Just remember that question. Okay. This is a case of a patient I met who had been on the surgical service and who was being transferred to medicine for ascites. The woman was in her early 80s who presented a few months prior to admission for CT-confirmed diverticulitis. And after a hospital admission for pain related to this diverticulitis with successful conservative management, she had done well, but then had recurrent symptoms with repeat CT showing a small pelvic fluid collection that prompted a second admission where she received 10 days of typical intra-abdominal antibiotic coverage. However, after discharge from the second hospitalization, she continued to have symptoms with CT scans showing ongoing diverticulitis. So she was admitted a third time for definitive surgical management. In the OR, the entire sigmoid colon was inflamed with extensive inflammatory changes filling the pelvis. There were no other remarkable findings in the op report, and a descending loop colostomy was actually performed. And she had a pretty routine post-op course, just requiring TPN for a bit, and she was ultimately discharged home, able to take food by mouth. Now we get to the admission where I meet her. About 1.5 months ago from the colostomy admission, she then represented to the ED for progressive abdominal pain, abdominal distension, and anorexia. A CT scan with IV contrast found new moderate volume ascites with some hyperenhancement of jejunal loops plus peritoneal thickening that could represent peritonitis. She was admitted to the surgical service and put on ceftriaxone and metronidazole, and a paracentesis was performed, showing about 3,500 total nucleated cells with 80% PMNs and a SAG of zero point 0.5. And my amazing colleague and Core IM co-host, for our listeners who listen to Core IM, Shreya Trivedi, was then called about transfer of the patient to medicine because her ascites was rapidly reaccumulating with ongoing severe pain despite nearly a week of antibiotic treatment. The acidic fluid culture remained negative at that time. So I'll let you chomp on that here, Mike. I'm very curious what you think about this initial part of the story.
Yes, great, lots of data. And I like that it's always good when we have cases with someone who's been exposed to healthcare many times prior. We've had hospitalizations that we've talked about prior in previous episodes recently. Because the question is it a sequelae? Is it something that we did to the patient? Or is it totally unrelated? And that's the scariest of them all, right? Because then you anchor on something of one of the other two. Before I go any further, I just, as always, want to make sure I've got the data right. So I heard that the SAG is zero point 0.5. Did I hear that correctly?
Uh-huh.
Okay. And then if you could just remind me of the cell diff again, the cell count and diff.
Yeah, total nucleated cells, 3,500, 80% PMNs, and that's it.
Okay. So, I mean, those aren't supposed to be there. Um, so yeah, uh, you know, so many different ways to tackle new ascites, and I think that we have that data there. So I probably won't belabor the things that flow up come upstream from that, but just remember that 75% roughly of the cases we see of ascites are going to be cirrhosis, right? So when you see someone with ascites, you're sort of trying to prove to yourself that this person does or does not have a, cirrhosis, right? So by far that's going to be the most common, even worldwide where TB rises, it's still by far the most common cause. And then you just run your cirrhosis differential, right? And then malignancy is 10, 15%. Heart failure, which I think of often as more a player with those other two, is actually relatively rare. It's like 3 to 5%. I mean, we see it all the time because we see a lot of heart failure, but it's not by far the most common. And then there's all the other stuff, which I'm sure we'll have to talk about because this is the nature of the podcast. But for this patient in particular, right? So just even ignoring for a second the cell count and the diff, we have a SAG that's zero point 0.5. And so that actually changes things a little bit, right? Actually, quite a bit, because a SAG of less than 1.1 generally is non-portal hypertension, right? It's a problem of really the pressure is not the issue. The issue is oncotic pressure, right? So it's not so much portal pressure, but oncotic pressure. So stuff's leaking out. Either it's being drawn out or it's not there in the first place, and so it's just liquid that's leaking in, right? And so, that changes things a lot. Cardiac ascites, cirrhotic ascites, these things are going to find their way over into the portal hypertension, right? Pre, intra, post hepatic. But we're not in that category based on at least this one data point. We are on the other side of things, which I think we think about less. And, could it be a lot of things? Yes. She is old enough that malignancy is basically always on the differential once you reach your 80s, right? And that's going to be in that category. And then the other is that other things aren't supposed to be there, right? And so she just had a colectomy. Did she perf? And if you perf, then that junk goes into the ascites and causes secondary peritonitis, generally, right? Which is what I think I'm worried she has. Um, I guess the question I'd have is, so she gets treatment, but it sounds like she gets treatment for peritonitis. It sounds like it was just ceftriaxone. So I guess your question would be whether or not she's accumulated enough hospital risk factors now that that's not broad enough. But relatively good treatment. It's missing anaerobic coverage, missing MRSA, missing Pseudomonas, kind of the big three that I would think are, if she was to fever or something, that I think would be missing here. The I guess I'll pause there and stop, but I'm wondering sort of, is she sick otherwise? You got ascites and she's rapidly accumulating, but is she septic? How does she appear? And then I'll ask all that boring past medical history questions as well. But let me just hear what she even looks like when we see her.
Yeah, sure. So when she transfers, she is like very, very uncomfortable because she's very distended with this rapid accumulation of ascites. And when you do like deep palpation of the abdomen, she's in a lot of pain. So like when you're going through her kind of her MAR when she was on the surgical service, you see like lots of IV dilaudid frequently. So I'll give you a little bit more information now, because you mentioned a question of perforation, which is the question we had. So really quick, just the rest of the fluid studies. Total protein was 3.5. That was high. Glucose 300 is normal, and LDH was 315 normal. So a CT abdomen with oral contrast to search for a post-op bowel perforation was performed by surgery already and negative. The report also mentioned a 1 centimeter pulmonary nodule in the right lower lobe of the lung that could be infectious or inflammatory, is what the read says. And when she was transferred to us, we have a very hard time disentangling the societies from a recent surgery. So I personally called surgery and asked what the sensitivity of that study was for leak. And they're pretty crystal clear that it was a completely normal study. But I was still skeptical. So I then got a CT urogram assessing for a post op urinary leak, and that was negative. And an acidic fluid creatinine was also negative. So, having been in the hospital for about 10 days now, her only symptoms are really these GI ones that she came in with. I just went over these high analgesia needs. She undergoes 5 total paracenteses this admission with large volumes of output, kind of like on the order of like a liter each para. And then while her second tap showed a decreased nucleated cell count down to about 650, the last tap this admission, the nucleated cell count actually goes back up to 3,700. And her only other symptom is some orthopnea, dyspnea on exertion. And this is kind of like reproducibly coming back with a large volume ascites. So everything is really ascites related. Her oxygen sats were normal. So for the 5 taps, she got all of the SAGs were less than 1.1. The cell differential remained neutrophil predominant with up to 7% mesothelial cells. And cytology was done for 2 of the 5 samples, and both were negative. Triglycerides and amylase were normal. Acidic AFB stain was negative, and serum tumor markers, CA 19.9, CA 125, and AFP all normal. So, we kind of just jumped through a big time gap here. Like basically, this was like a whole hospital admission for this issue that I just went over. So I wasn't in this position, but a hospitalist was in the position now where kind of this is where the patient has landed. I'm curious, like the patient's like stable enough to go home for discharge in terms of like vital signs and labs, but like what would you call this at this point? Like, what's your best guess? How would you treat it? How do you like safely get this patient home? Because we still don't kind of have an answer for this. I'm just curious.
Oh man, you're the guy asking me like I walk in on Monday and I've seen my list for 18 minutes and you're like, all right, this person's getting out of here. So I think I need a little more data, but what am I calling this? I guess I'm saying rapidly accumulating ascites of unclear etiology. Non-portal, possibly, is maybe as far as I can get. So you've exonerated like quite a few things, I think, or I mean, I think we can feel pretty confident now that this is probably not blood, urine, or poop, which are really the three big things that can cause that secondary peritonitis, particularly after surgery. You've I the high protein that pushes us sort of away from malnourished states, protein wasting states. You could have a protein wasting enteropathy after this procedure, right? But that doesn't appear to be the case. That would have a low protein in the ascites, right? Because you're just losing all your protein, so it's low everywhere. But this would be, I mean, this would fit with sort of there's something there that's not supposed to be there. Um, cytology is good for peritoneal carcinomatosis, right? But it's not necessarily good for something else that's causing, um, another malignancy that's causing ascites. The problem with is that most of those things are solid tumors, which are going to cause it through a different mechanism, right? Generally, portal hypertension, um, compression of the portal vein, or massive liver mets, things like that. You can have MPN that causes kind of like this imaging negative portal vein. I think it causes a thrombus, portal vein thrombus. I guess it wouldn't be imaging negative. It can do something to the portal vein that causes it. But again, that's portal hypertension. So we're in sort of a weird place where we think this is non-portal, but we don't have a good cause. And you've also gotten multiple contrasted studies that you would expect to have shown a mass large enough to cause this degree of rapid accumulation. Because that's what's weird about it is it's rapidly accumulating. And when I think of rapidly accumulating ascites, I actually usually think about portal causes, right? I think that's just generally who we see oftentimes, or really severe malignant ascites as well. Which I just it'd be hard to believe that cytology is negative times two. And she just they did like they opened her up, right? I mean, or at least they did laparoscopy, right? So you would expect that there was some pathology sent from that. I mean, if you don't like what you see with cytology, you can always get imaging, but I mean, diagnostic gold standard is like you just open them up and take a look and see what's inside. They didn't go looking for that when they did it, but they did kind of do it. And then, I don't know that a PET scan is going to be super helpful here because she just had surgery in her abdomen. So I think it's just going to be it's just going to be an abdomen that's on fire. So I don't know that the PET scan is going to be super helpful here either. So, yeah, I don't know what to call it other than non-portal hypertension. I think what I may need to look up is I think that the sensitivity specificity of SAG is pretty darn good. I think it's like 95 to 98% somewhere in there. That does mean that there's always like that what 2 or 3 4% chance, but I don't know what causes that full transparency. I don't know those cases. So I think what I'm going to call it is
And Mike,
non-portal.
maybe,
Go
yeah,
ahead.
and Mike, just to interrupt, because you're right. We found out that the sensitivity of these CT scans was like very, very high for these like post-op etiologies, which is like what we were all banking on because like she just perforated like her diverticulus, and the studies were negative. So I guess like how do you incorporate the cell count being so high? Because like the nucleated cell count again, like the last one, The last one was back up to 3,700. Like, does that influence anything for you?
I mean, it does. I just don't know what to attach it to. I mean, I think it makes me concerned that there's some ongoing infection or inflammatory process. But I can't quite put my finger on what it would be. Particularly, what type of cells were they? Were mesothelial cells mostly, or I just forget what were they? They were PMN.
Mostly PMNs.
Okay, all right, yeah.
Like it's always like about 80% PMNs, and then yeah, up to 7% mesothelial cells for one of them. Yeah.
Okay, yeah. So I mean, that's like not even just inflammation, but it's like kind of an infectious inflammation kind of response. So, and none of those cells, they look like regular old PMNs. There's nothing, they don't, they don't, they themselves don't look to be malignant or neoplastic. Okay. Yeah. And no cultures, you said, have grown,
Yep.
um,
Culture is all negative.
including, I mean, again, AFB was sent, right?
AFB was sent once, negative.
Yeah. No, I don't know that I have. I don't know. I mean, I think it's like almost like an occult or cryptogenic infectious ascites, like secondary peritonitis. But
Yeah, well, Mike,
I don't know what it is.
I'll give you a little bit more because I left service. You know, oncoming hospitals was faced with the issue that you just came up with, and I mean, w when I was passing off this patient who I like, had for 48 hours, I was like, the only thing I could think of after the surgery was she had some sort of like micro perforation or like anastomotic leak that led to peritonitis, and then that healed, so then the CTs were negative for it. So that was like, take that with what you will, maybe consult ID, which actually ID was consulted, and they ultimately ended up calling this like some sort of secondary peritonitis. She was given a 2 week augmentin course and then discharged. But the story isn't in there. So a month later, she has a follow-up visit with surgery, who commented she's continued to have postprandial abdominal pain and fullness. She's a descended belly on exam. And then 1 month after that surgery visit, she actually sees hepatology. This is due to abnormal LFTs that were measured in the outpatient setting. She had like a ALK Phos of 200, AST of 140, and an ALT of 155. Bilirubin was normal. And the hepatology notes confirm her symptoms are basically the same. But since her GI symptoms are ongoing, she's now lost 30 pounds. And then, other than the Augmentin, they note she had started diclofenac and advised she stop this in case this was a culprit of drug-induced liver injury or DILI. So they then repeated her LFTs a week later. They remained abnormal. And then a right upper quadrant ultrasound showed a fatty appearing liver with a nodular liver contour. And INRs remain normal. Her albumin remains only mildly low, not that impressive. And her platelets were now 700,000, and she was referred to the hospital for a liver biopsy at this point. So this is kind of curious because now she's seen hepatology and her like LFTs are abnormal. The AST, ALT, and ALK Phos are up, but the SAG is, we know the SAG is low. So like, how do you navigate this tension? What are you kind of latching on to as more specific here?
Hmm. Did you say the platelets are 700,000? Yeah, so like that also doesn't really fit portal hypertension, right? I mean that's maybe you started off high and you came down, but like that really speaks against it. I mean, a nodular liver, you said nodular, right? That's what it looks like to some degree. Yeah. So, I mean, it's non-specific. We certainly think about that as cirrhosis. How high are the transaminases for her? I
I was just
may
like
have
in the
missed
hundreds.
in the
Yeah,
hundreds.
not very
Okay.
high.
And, she has two clear exposures for drug-induced liver injury. I, you know, to damage the liver and cause ascites, generally you need something that is causing portal hypertension. The sort of, I suppose, independent mechanism would be that you have something that's like infiltrating the liver and also separately causing this. When the platelets are 700,000, that does actually make me think of something like MPN, right? Like the JAK2 mediated diseases, and they do cause, from what I remember, those things do cause ascites, but I'm pretty sure that that's through polar vein thrombus,
Yeah.
which and I
Yeah, it's
guess we've had that case in the past, Andrew, right, where we had like the imaging wasn't powered for it, and do we get a venogram or something to look for that system better? Um, I don't know. That still should have a SAG that's higher than 1.1 though, so it would be a very, very weird presentation. Smear? Can we at least see what do these platelets look like? What do the rest of the cells look like?
Yeah, yeah. I think you're on exactly the right track, Mike. I don't know if we got a sphere. We'll call them normal. We'll
Okay.
call them
All right.
normal and to believe the SAG. And at this point, who really had to navigate this tension was not myself, because this is many months later now. So actually at this point, just to loop back to the beginning of my stupid transition into this episode, do you believe in aliens? We are not alone today. I have Megan Cynic here today, who was actually the resident who we really passed this case on to many months later. So Megan, do you want to introduce yourself really quick before you kind of take us on this journey that you all navigated?
Yes, I'm Megan. I'm one of the second year residents at BI. I want to be a hospitalist. Trying to think if there's anything else anyone should know about me, but those are the main things. Yeah, I can go ahead and get started on how our team was approaching this. Um, so so this was her fifth admission now, I think. And she was initially on the liver service first, and that was because there was like this question mark of based on the imaging if there was like underlying cirrhosis. And so she had all of the like liver bomb labs that everyone gets sent for like elevated LFTs were sent for her. So yeah, and they did like a very thorough history. She drank less than 7 drinks per week, no supplement use. Her autoimmune workup was unrevealing. Her ferritin, not concerning for hemochromatosis. Ceruloplasmin was negative. Alpha 1 antitrypsin was normal. And then she ended up getting her liver biopsy, which just kind of showed no evidence of advanced fibrosis, maybe some background biliary features that raised a differential diagnosis of medication effect versus primary biliary disease. And so, given all of that workup, and then also she had recurrent like abdominal imaging at BI at the hospital that like showed normal liver contour and parenchyma. So I know her like previous ruckus had showed like maybe there was some nodular contour, but she had repeat like normal imaging. And then this like kind of normal cirrhosis workup. The liver team kind of concluded that likely her abnormal LFTs were thought to be a DILI from her PO diclofenac that she was taking for her abdominal pain. And then given that this ascites was low SAG, they decided to transfer her to the medicine service, which is where I met her. So they were kind of saying, this isn't us anymore. You guys go for it. And so to kind of set this scene now, we had like a whole brand new team taking over the care of this patient. I think like attending, resident, intern, all new. And we all just felt like we didn't have a great grasp of what was going on and like because she had been seen by so many different teams and so many people. And I think we were just kind of confused on like what people were thinking. So we just went back to basics. So once again, we knew that this recurrent ascites had started after these abdominal surgeries. So we reached back out to the surgical team and we're like, okay, 100% is this not related to her proceduralization in some way? Is there like some leak, some persistent inflammation? They once again basically said, absolutely not. This isn't us. And then we reached back out to the hepatologist because while this was like low SAG, high protein ascites, her liver biopsy wasn't like completely normal. There is some evidence of this like mild mononuclear inflammation. And then that like biliary finding. And they basically were like, this is what we see in DILI. This is not some like underlying liver pathology. And then they said, maybe this is cardiac ascites. You should get an echo. And so, we did that, which wasn't that revealing for anything. And so, we kind of set our groundwork again and we're back at square one. with this like recurrent low SAG, high protein, high cell count ascites that had no culture growth, no revealing cytology of after seven, by this time, seven paracenteses, all kind of with that same feature. Um, we'd had abdominal imaging that was unrevealing for any kind of like primary malignancy. And then we were also thinking, was there like a pancreatic abnormality that's like causing this, but nothing like that. Her lab workup had been negative for any kind of like nephrotic syndrome or protein losing enteropathy. And then we had mentioned the culture was also AFB negative, and she didn't have any like specific risk factors for TB. So at this point, we reached out to ID with the question basically, one, like all of these paras have a cell count with like this high PMN count. Like, do we need to treat this as an infection? Does she need to be on some kind of like prophylaxis? Like, what is a safe way to do this? If we do any of this continue to work up outpatient. And then two was just kind of like any other ideas, like trying to reach out for help. And so they recommended no treatment for SBP and just kind of monitoring how she does without any antibiotics. And then once again, recommended we consider TB peritonitis. Kind of despite negative culture state and no risk factors, I think any good ID doc is going to have you consider TB. And then they also threw out maybe this is a retained like diverticulitis causing a smoldering sigmoid diverticulitis in the background. And then they also just said kind of consider atypical causes, including cancer like a lymphoma, even though there's negative cytology, consider a peritoneal biopsy. So that was kind of a lot of information that we went through. So I can pause there and kind of give you a chance to process that her like second round of workup. And like especially with that differential from ID, I'm wondering how you're thinking about this patient and where you would kind of shift the focus of your workup for her.
Well, first, I mean, the principles really stand here, right? Like it's pretty clearly not, I mean, cardiac, right? Also high SAG, right? So I'm not surprised that there's not something there. And I guess do we have like a gene expert available to the, I mean, right? Because like AFB is good, but like, that's just, I mean, right, it's very sensitive, very specific. And then I guess the other thing, right, would be like something fungal. I don't know if her TPN predisposed her to like a fungal infection that maybe, I mean, do you think bacteremia, but maybe she was transient bacteremia. I don't know. She cleared it, it got stuck in her abdomen. Just like other, like sending a beta D glucan, in the serum. I don't know. And yeah, I mean, peritoneal biopsy, I still think a PET's not going to be useful for all the things we talked about. I don't know the testing characteristics of acidic ADA, like adenosine deaminase, to be honest. So I can ask for it, but I won't know how to interpret it. So I'll try not to ask for it. And then I guess the other thing, so did they send triglycerides at any point? Because chylous ascites will look like this. And I suppose, you know, um, I'd like to believe that there's nothing wrong with the surgery, but every once in a while you can nick a little lymphatic, and then the lymphatic leaks. Lymphoma can also do that, but I don't know. Those are my questions. It sounds like half of Harvard saw her, so I don't know what I'm gonna have to offer on a late Wednesday night. But those those are my thoughts.
I don't have the triglycerides off the top of my head or written down anywhere, but I think they were unrevealing. Um, I'm trying to think of what else. I believe she had, I don't think she had like a glucan sent, but I think she had maybe like fungal cultures at some point sent and like repeat. I feel like there are other things besides just the one like A of B culture. I think there is more done. Sorry, I do not have that written down, but I will say where we went next. um, so with her, I think our team really thought like this has got to be some kind of cancer, mainly just from like looking at her. She was very cachectic. She'd been experiencing like unintentional weight loss for months. And I think it's easy to say, like she's also having this abdominal pain, bloating sensation, painful ascites. So definitely that could be contributing. But I think all of us in the back of our mind were like, there must be something else going on. And
Is
so
it the lung? Is it that lung nodule?
yes.
Ah,
So what she had, if you notice, we said like her abdominal imaging didn't reveal any kind of malignancy, but she hadn't actually had a CT chest. And so that's what my attending, Dr. Wise, shout out, had recommended. She's like, you know what? She hasn't been fully pan scanned. And so her chest CT showed interval increase in a 1.1 centimeter spiculated right lower lobe nodule, along with new and enlarging mediastinal and right hilar lymphadenopathy, raises concern for malignancy. And then she also had a large left pleural effusion, which had like very similar studies to the like previous paracenteses with like exudative simple effusion with negative cultures, negative cytology. And so she did go undergo inpatient PET, which basically just showed like the same things as the chest CT. Part of the reason for this is because there had been like this lingering question of peritoneal biopsy for her, and we were all thinking of what would be the target for that, or would you just go randomly sampling in the peritoneum? And so we were trying to see if there was a better target for biopsy for her. um, I guess should I just go on to the case conclusion then? Okay. So she was then discharged from the hospital basically with a plan for outpatient pulmonary nodule biopsy. And then she was just going to follow up in this like transitional oncology clinic. So we had a hunch this was all related, but we didn't actually know for sure yet. Um, and so then she got her biopsy done, which initially reported metastatic adenocarcinoma, which I think in my mind, I still was like, where that, like, what is it? But then later, like a couple days later, they revised this report to then say malignant mesothelioma epithelioid type. And so then she most recently saw her oncology team, and they noted, although we do not have biopsy proven evidence of metastasis, we suspect that the patient's mesothelioma involves not only her regional lymph nodes, but also her peritoneum, as evidenced by her history of recurrent culture negative ascites. So they are planning to approach treatment as advanced unresectable malignant pleural mesothelioma. And we're planning systemic chemo for her last I checked. So that is our
wow. I
case.
mean, sorry that that's what it is. But that is really interesting. I mean, obviously the mesothelial cells were the tip off, right, in that fluid, and I just thought about them as reactive, and sort of discounted them. And I even wrote down the palm nodule on my notes here, and then I just never looked at it again. So that's a good point. The reason I think that I didn't come back to that palm nodule is that it sounds like they're, I guess, a question. So are they thinking that this is carcinomatosis from this mesothelial carcinoma? Mesothelioma? Is that, do I have that right?
Yeah. So Mike, the oncologist, even because that was kind of the precise question we all had at the very end, was kind of the mechanism of the ascites, if
Mm-hmm.
that's the case, because
Mm-hmm.
there isn't any disease in the liver, so we know it's a non-portal hypertensive, like you said. So what you're really left with is like the idea of peritoneal carcinomatosis is something really like lining kind of, the serosal
Mm-hmm.
space. So they looked back at the op report, which is actually why I mentioned the op report at the beginning. There's no comment of like nodularity, like when they went into there and the belly. All they saw was like inflammation. So we even took a look to see was there something there in retrospect, but no. I think the only mechanism that was kind of left is something that's kind of lining and inflaming this
Mm-hmm.
space.
Mm-hmm.
Yeah.
Interesting. Yeah, because I think cytology's pretty good for peritoneal carcinomatosis. The tricky thing is, right, that malignancy can cause ascites through other mechanisms aside from peritoneal carcinomatosis, and in those cases, their cytology will be negative, and then you get confused. But so yeah, that I think that was the tip off for me. And I'm actually just reviewing the clinical problem solvers ascites, and there it is, non-portal serositis, cancer, mesothelioma. It's right there. So that's it checks out. That's very interesting. So I think it's always good to reflect. I think that big tipping point, the big slipping point for me was the fact that the cytology was negative multiple times, and also the fact that it was negative in terms of portal etiologies, and so that. And then, of course, I think for everyone throughout this entire case, right, the fact that she just had surgery in the same place is very, very hard to ignore. And did the who knows? Did the mesothelioma in her peritoneal cavity predispose her to a worse course of diverticulitis? Who knows? I don't know. Maybe they're
The
just
the
not related.
oncologist said the same exact thing, Mike. And we'll get back to the cytology in a sec. I'll just pass it to Megan for her reflections
Yes,
first.
please do.
Okay, I apologize. My reflections are a little like broad spoked of like my whole career in medicine, what I was thinking about. But yes, my reflections on this case, I think um, during my second year, I realized it's like very easy for my like light for internal medicine to dim a little bit just because, my responsibilities have doubled. I'm more anxious about the future. And I think for me, this case, while not like an ideal ending in terms of like the malignant mesothelioma aspect of it, it was kind of reminding me why I chose to be a hospitalist. And I was reflecting a little bit on when I even applied to residency. I wrote my personal statement about there's a book by Joan Didion called Blue Nights where she says, you think the end of the day will never come. You experience an actual chill and apprehension of illness at the moment you first notice. The blue light is going, the days are already shortening, the summer is gone. Blue nights are the opposite of the dying of the brightness, but they are also its warning. And she wrote that when she was reflecting on like the night before her daughter's death. And I kind of wrote my whole personal statement about this idea of that everyone in the hospital exists, in this space between life and death. Everyone's their like own shade of blue. Um, and in being a hospitalist, you kind of get to be that guide through the blue night because, as we saw in this case, every consult team has like their approach to their problem. Like the surgery team says, this is not a surgical problem. The liver team says, this is not a liver problem, but it's the role of the hospitalist to really synthesize this information and create like a comprehensive narrative that serves like as a framework for the patient to understand like their illness, understand their blue night, and give them the sense of ownership over all these sensations that they're feeling. What does this actually mean? And so while I wrote that personal statement at a more like idealistic time in my life, I think the ideas still hold for me. Of just like the honor of being a hospitalist and how you get to juggle all these pieces of information and weed through all these different buckets and like all these different teams. Um, and I think even though like the ultimate diagnosis of mesothelioma can be really difficult to reckon with, I think for this patient, she's had so many admissions and not knowing what was going on and just feeling horrible and feeling so in pain. And like that was really hard for her to grapple with. And so to be able to deliver like some kind of explanation and like reasoning through that, I think was very important for like her overall morale and willpower. And yeah, so I think it was just an overall like very, very like enthralling case to be a part of. Um, and then that's kind of my more, I guess, I don't know, emotional reflection of the case. But then otherwise, I think just like more um, like bureaucratic things. I was reflecting on how extensive her workup was and how, at least just for my admission that I worked with her, was like 3 weeks. Um, and eventually by the end, we kind of had to think about, what is actually keeping her in the hospital? Is it our academic curiosity of needing to do like more workup and find an answer, or was there an actual reason to be hospitalized? Which I think that question was kind of raised early in earlier admissions as well. And so that's why for that last little bit of her workup of the biopsy and, getting established with the oncology clinic, like those things were done outpatient because I think as we kind of discussed, like just being in the hospital for so long with all this pain and no answers was really demoralizing. And so while I love inpatient medicine, because you ideally get your answers quicker and there's that sense of control, it's important for me to always think about, does this patient truly need to be admitted, or can we set them up with a good outpatient plan? Um, and then I just have two more kind of reflections. The third being trust but verify, the classic teaching I feel like we hear all the time as residents. As you may recall in the beginning, when our team got her, we basically repeated steps that had already been done before. We reached back out to the surgeon, we reached back out to the liver team, because I think especially with our EMR, there's a lot of copy forwarding, a lot of errors that may be propagated. It's really hard to tell what people are truly thinking. And so I'm always an advocate of just calling and discussing and trying to make sure everyone's operating with the same baseline level of facts. Um, and then my final thing was just that it's always all about the tissue, not just getting it, but where the tissue is and what stains are involved. And on that, I will pass it off of my reflections to Andrew.
Uh, Perfect segue. My reflections are much less eloquent than Megan's, but I thought I'd close this out with a quick aside on mesothelioma, which is quite rare cancer. It has an incidence of only about 3,300 new cases of pleural disease in the US per year, but it's definitely important to consider in the right person. Mesothelioma is a malignancy of the mesothelial cells that line our serosal cavities and can be born in the pleural space in about 85% of cases, the peritoneal space in 10 to 15% of cases, and the pericardial space in about 1%. And basically anything that leads to chronic serosal inflammation increases the risk for genetic changes that can result in mesothelioma. So think like recurrent serosal inflammation, a history of radiation, classic association with asbestos inhalation. These are all important substrates, but you'll notice that actually in this patient, she was a former smoker, but she actually had no occupational asbestos history. So asbestos is not necessary to basically acquire the disease, but smoking probably was her biggest risk factor. Tends to present insidiously, which means patients typically present with advanced disease after experiencing minimal symptoms up front. And this case is actually a really good example of how even in cases that are intercepted early can be very challenging to diagnose without an understanding of the specific diagnostic pathway to confirming mesothelioma. So if you go on our website and look at our approach to cryptic cancers, there are really three main reasons why a cancer may go undetected despite there being something clearly wrong with the patient. One is a radiology challenge, like you can't see it. Two is a pathology challenge, like we're not testing for it properly. And three is a context challenge, like we're being distracted by a very unusual presentation. Think like HLH from lymphoma. So within this framework, mesothelioma really presents a very specific pathology challenge within the realm of serosal fluid testing in the form of cytology specifically. So the issue isn't we can't see the cancer. We see the pleural effusion, we see the ascites, we see the pericardial effusion, but it's really the cytology challenge. And Mike, you actually kind of like comment on this and alluded to this. So we're going to talk about cytology. So to understand fluid cytology in mesothelioma, we need to understand what the heck mesothelial cells are. So after doing much reading, what I've come up with is that mesothelial cells are basically sensitive chameleons. They're sensitive because they shed from the mesothelial lining into the serosal cavity as a result of pretty much any pathologic process that results in effusions or ascites. And this is basically your reactive mesothelial cells you brought up, Mike. So think like inflammatory, infection, traumatic. Mesothelial cells are also chameleons because their morphologic appearance is extremely variable. And what I mean by this is they can be so floridly atypical appearing that they mimic malignancy, so they're not mesothelioma, or opposite, they look very typical, yet there's still underlying mesothelioma. So what all this means is if you have mesothelioma on your differential diagnosis for recurrent serosal fluid, you need to talk to your lab specifically about this so they can do immunostaining for it. So in our case, what turned out to be reactive mesothelial cells, this is what they were called on our cytology reports. When they immunostained it in retrospect, like after we got the tissue diagnosis, our patient's mesothelial cells had loss of BAP1 staining, which is quite specific for mesothelial cells. So actually, the cytology was positive. The pathology was there. It's just that the cells look normal on the initial cytology assessment. and the workup stopped there because there was no atypia basically. But if the suspicion is high enough and you reach out to the lab, they'll actually do the specific immunostaining for you. And for our case, two of the cytologies we sent actually did end up positive, confirming the final underlying mechanism of disease here. So there's like many more nuances of mesothelioma that I can go on about. I'll leave it the rest for the websites. Megan, Mike, thank you for talking about this very, very challenging case. I definitely think it's one for the books. Any final thoughts from you guys?
I mean, as always, humbled in these cases, and I just a plug for hospitalist careers. Thank you, Megan, for preaching to our choir here of two. But no, I think that's what's so cool about it, and I think the job is best when you are, you're the orchestra leader or the quarterback, right? All of those sort of things. And I know that's particularly in residency, sometimes it can feel like you're just sort of managing consultants or, like a glorified secretary, shade secretaries, but right. But right, you're sort of just like managing personalities and sending, copy and pasting a text from a GI person to a ID person, right? You're just like an intermediary. And just like flip that script a little bit. That's not what it actually means to be a hospitalist. It can feel that way at an academic center, but you're allowed to talk to radiology. You're allowed to make decisions. You're allowed to disagree with the consultants and challenge them and reconsult them. And once you become an attending, you're allowed to ask to speak to the other attending. So you should own the job and own it, because that's, I think, the way. And when the patients see that also, to speak to sort of helping them make sense of things, I think they sense when there is a lack of diagnostic clarity. And in those moments, because they happen, because medicine's hard, I think what maybe sometimes is helpful, at least, is like, okay, they don't know exactly what's going on, but this person's at least, it's clear who's in charge, or it's clear who is leading the charge. When I have questions, it's clear who's going to answer those questions or find the person who can answer those questions. I think when it's just sort of an amalgam of specialists, I think and they don't know what's going on. I think that's scarier than if you have that amalgam of specialists, but you do have someone who can come back at the end of the day and sit down and say, no, this is where we're at right now, even if that's not a final answer. So thank you very much, Megan, for joining us.
Yeah, thanks for having me. It was fun.
This has been Diagnostic Atypia with Doctors Andrew Sanchez and Mike Arcieri. The show is produced by us with the help of Podcastle. Our intro-outro comes from the album To the Surface by pianist Lawrence Fields. If you enjoyed this show, consider subscribing and sharing our episodes with others. If you have your own atypical diagnostic journey to share, please reach out to us, dx.atypia@gmail.com. We'd love to discuss it with you, and we welcome medical students, residents, and even seasoned attendings. Happy zebra hunting. We'll see you next week.